and I'm also in the Department of Family Medicine. And I am here to talk with you about dissemination implementation research. Can you just tell me, are you particularly interested in this topic, or are you just kind of here with a lunch then because you're always here? Is there something specific you want to know about DNI, or just kind of be aware of it?
I guess I'm a fellow, and my fellowship is in implementation of pharmacoeconomics.
Okay.
So it's very relevant to.
Okay. Okay. Anyone else? Yeah.
I'm a human factors engineer, so traditionally I focus more on the evaluation of different things and how to do it, and less on the how to actually implement it. So I'm interested in that piece of it.
Okay. The rest of you here for the lunch. Okay. All right. So this is just going to be an overview of what dissemination implementation research is, and a little bit about why we might want to have dissemination implementation research, and kind of a little bit about some of the frameworks and models that guide it, and where you might go for more training or research. So, the first thing I'd like to define and describe what DNI is. I'm just going to call it DNI. It stands for dissemination implementation. And contrast it with doing implementation and dissemination activities. Describe key conceptual frameworks and resources. So first of all, what are we talking about? I just want to get a kind of few terms out there, because it gets really confusing really fast when you start opening the floodgates for everything, studying everything, which is kind of what you do in dissemination implementation. Okay, so with your mouth full, give me some examples of some programs, policies, approaches that are intended to have a positive effect on patients. Just give me a couple. Somebody?
Target zero.
Target zero. I don't know what that is, but what is that?
It's like a checklist we go through every day for trying to minimize preventable complications.
Okay, so that's the thing you're trying to do, and if you do that well, your patients have less complications.
Yeah, less VTEs, less catheter-associated UTIs.
Okay, one more.
Best practices.
Best practices. Narrow that to something?
Getting your influenza vaccine. We have a thing that comes up on Epic. It says the patient has or hasn't got an influenza vaccine this year. So best practices is that they implement that and they give the shot.
Okay.
Until you have your shot, it pops up on every provider screen when they see the patient.
Unrelenting till it's done. Okay. So thank you for those examples. We're going to call these evidence-based interventions, or they're just the interventions, okay? So interventions are the things that you're doing to try to have an effect on your patient or your client, I guess, if you were in a community center. But we're just going to say patient because we're standing in a hospital. All right. So, and if they've been tested in a rigorous way, like an efficacy test, then they're said to be and found to be efficacious. They're called evidence-based interventions, right? So what are some ways to get those evidence-based interventions to be taken up and delivered well? How did they get you to use the zero thing, target zero?
It's on every computer screen.
Yeah, that's part of it. So the fact that
Making it part of the system.
public or like very
In your
prominent.
EMR.
Yeah.
What else?
Like a training included on it.
Yeah.
Training.
Talk about an orientation. Meetings.
Okay.
Somewhere on our badges.
On your
It's-
badges.
Yeah.
It's expected that it's part of the patient presentation every day. So we've sort of standardized that as like part of rounds, I guess.
So maybe you get evaluated in some way if you do this stuff.
We contracted the pharmacist to do this sort of blood clot prevention part of it, and they actually put a note in every day, so they've sort of delegated some of the responsibilities to different practitioners.
Okay. So those things are not the evidence-based intervention. They're the implementation strategies. So the idea is you've got something that is supposed to directly affect patient care so that you get some health outcomes. And then you've got these other things you do to get that thing in place.
okay? So just try to keep those straight, because otherwise, like, it's all implementation, right? Like, you're always implementing something or disseminating something, and it gets really, really confusing. So let's try to keep those straight. So a few other clarifications. Implementation is the process of putting a decision or plan into effect. We all implement. That's kind of what you do with patients all the time, right? It's what people do. So that looks like things like, supporting and identifying champions and providing technical assistance. Those are just some examples. Implementation research, however, is the scientific study of the use of strategies to get people to adopt, implement well, disseminate those interventions. So it's a specific kind of somewhat new area in the health-related realm that recognizes it's not just about the intervention, it's getting that intervention out there so that people do it. And so there are people who study this, and we call those people implementation scientists or D&I scientists or D&I researchers. So sometimes I see it thrown around, well, you're an implementation expert because you use target zero. Well, no, that probably doesn't make you an implementation scientist. It makes you a good clinician who's doing what you're supposed to do to implement good patient care. So the other definition here is dissemination. So dissemination is kind of spreading. Like, say you've got something that works and you get it to be implemented here at Children's Hospital, but every other children's hospital isn't using it. That would be dissemination. You're trying to get it out there so that everyone's implementing it, and it becomes what? Standard of practice. It becomes what people do. And dissemination research is kind of similar in that you're studying the spread, okay? It gets a little confused with like marketing and things like that, and there are some overlaps, but there is some differences. All right, so why is this important? Why would we do this? I've got some answers, but what do you think? Why would you study implementation and dissemination as a science?
Better patient outcome.
Yeah, because part of it is you have an intervention that works, but the other part is it being used? Because if it works but it's not being used, so here's the classic slide. I think those are trees. And this has been floating around. I borrowed this from Borsika Rabin, who's a leading D&I person in the country and works with us. If an intervention works and nobody can use it, does it still make an impact? It's like, does a tree fall in the forest, and if no one hears it, whatever. So that's the main point. So have you ever seen this T1, T4 continuum? Familiar with that? Okay. So along the lines of translational research, we here at Colorado have something called a CTSA grant, or Clinical Translational Science Award. And the idea of that, it's like a $50-something million grant, so it's a big one. And it's to support this T1, T4 continuum. So over here, is this a pointer? Yay, okay. So over here we have bench. Can we invent a solution to a health problem? I don't know, some new pharmacotherapy, you're interested in that, Is there a new drug that helps treat condition X? Then, does that drug work, not just in the lab with microscopes and chemicals and all that, does it also work with animals, and does it work with humans? So that's a T2. And then, can we actually use it with patients? So that's more like your efficacy type stuff and maybe into effectiveness. And then can it be delivered reliably in practice, and then can it benefit the community? So it's this space over here that D&I research sits in. So efficacy means, does something work under highly controlled conditions? And effectiveness means, does something work under more normal clinical conditions? So D&I science kind of is in that space where you're looking at effectiveness, and then you're looking at how it implements and spreads. So the reason why D&I also is important is just the time frame of everything. So this is a typical time frame of 7 years. Here's your R21. You guys researchers, mostly? Sort of, okay. An R21 is like a novel exploratory study. So that takes 2 years that you develop and test your intervention. And then a couple of years later, you get your R1 the first time when you submit it. And then you recruit, randomize, follow up, analyze, publish. Okay, so that's 7 years. Meanwhile, these things have happened in 7 years. So, from YouTube, iPhone, Android, iPad, so the pace of things happening out in the world is rapid and we're slow as researchers. The other thing to think about is the publication pathway. So you say, okay, I developed my intervention and I'm going to publish in a good journal and it's going to change the world, right? Well, the problem is, just the publication pathway takes a long time, and maybe not everybody will read it, not everybody will do it, and even if they read it and believe it, which are two big ifs, it doesn't mean they're going to actually know how to implement it. So this is a figure that's been touted out there. It takes 17 years to turn 14% of original research into the benefit of patient care. Now somebody did a study on that. I borrowed this from David Chambers at NCI. I borrowed like a few of his slides. He was here last week. And he said, use them. So I am. But the point is, don't get depressed as researchers. You're different. Your work does make a difference. But we need to speed this up. We need to get things out there benefiting people better and faster. And so to further hammer this nail in the coffin, even if your intervention is 100% effective, it's only good as whether it's adopted, people are trained to use it. You mentioned training as a mechanism. They choose to deliver it. The eligible populations receive it, and it can be sustained. That's a 3% benefit if there's 50% students in each of those steps. So we need to work on that. Now, I apologize. I don't know why I couldn't get this to work. But right here is the things you're doing for your intervention. I don't know why it didn't show up there. But so these are the intervention. And then here's your outcomes that you're trying to get to. You're trying to get to improve health status, symptoms, function, satisfaction. So the typical study that is more of an efficacy study just does that. It takes the intervention and then it looks at the outcomes. But there's a lot of stuff in the middle here related to the how, all the implementation outcomes, and the service outcomes. That is the realm of what implementation science would study. It's all that stuff in the middle. So that if you have an effective intervention, it can actually be taken up and used in practice. So you're getting kind of the point of what I'm saying, right? That's why. So this is why it exists. So one thing, we had a workshop last week called Designing for Dissemination. It was like a day and a half. Did anybody come to that? No. Okay, that's fine. So the idea of the workshop was we're trying to get people to think sooner when they develop their interventions, these implementation and dissemination issues right at the beginning as you're developing it. So it's not like you wait till the end and then you have something that is not going to be able to be implemented or disseminated very well. And so it's kind of moving all of this, kind of while you're doing this development work, to be thinking of the end in mind. How would this work? Now, a bit of this is the trajectory of where things are going. For example, I started out studying care managers. You guys have care managers in practice, or case managers, or care coordinators, or they're called lots of things. So this was like about 15 years ago. I started studying care managers, and everybody's like, how are you going to pay for that? Nobody has those. So part of it is you're thinking of like how policy or payment needs to change. But, now there are care coordinators, care managers, whatever, because the research has been done to show that they can be effective in some ways. So sometimes the policy needs to catch up. So it's not always in today's world with today's circumstances, it has to fit. But you have to be thinking about that, right? So that, when you get to actually disseminating, who can deliver it, how it fits with the patient population, that you've got the kinds of things you need, etc. So where does D&I research fit? I know this from Russ Glasgow. He's a D&I scientist here at the University of Colorado and the lead for our D&I program. And he kind of adapted this from some other work. You've got overall, health and community services, and health services research is part of that. And you'll notice quality improvement is over here. It's not in the health services research, but it's related. QI research is kind of called quality improvement science. And then you've got implementation science as a part of health services research. And then you've got dissemination, implementation, and then a big, big overlap is pragmatic. So it kind of fits in this space, sort of. All right? So it's a kind of a part of health services research. So what are some ways to examine D&I? This is a busy slide with a lot of things on it. When you do an intervention-focused study where you're trying to determine if your intervention has evidence, if it works, what are some things that you do to make sure that that is your intervention and nothing else?
Develop the ideal sample. It's hard to find.
You restrict your population to ideal candidates. Now people are going to be problematic and mess things up. All right, what else?
I mean, randomization is what we do typically.
Randomization. So it's like random factors. So, if it's something else, that would get accounted for. What else?
Representativeness.
Okay.
But
Maybe
they also
try to-
look for the people who screw things up.
Right. So try to think of the opposite of some of the things that are circled up here. One of the things is fidelity. So with your Target Zero checklist, you got the checklist. People are supposed to do everything on the checklist. If they don't do them, they're not having fidelity, right? It's like, do those things, do them how we tell you, and don't do anything different. That's fidelity. So that we know you did the complete thing. So that when we look at the outcome, right? So those are kind of the nuances of how you would study an intervention, more in its pure sense, to make sure it's really the intervention. With D&I, what you're trying to do is study real world. So therefore, you throw off kind of a lot of those constraints. All right? Because do you believe if I give the Target Zero checklist to you here, and to you somewhere else, and to you somewhere else, that if you're really good at your setting, you'll know some things about your setting to tweak it a little bit to make it work best for your setting. And it could actually turn out better. Now, you could say, I don't care about this thing. I'm not really going to use it. I'll do one thing just to kind of show them I did something, but I don't really like it. That's kind of missing core component. So that's different. But I'm saying if you adapt it so that it actually fits better in your setting, that might be a good thing when you're rolling something out and studying its rollout into real world, right? So that's kind of in the middle there, adaptive. Multi-level is another key characteristic. So we're not just doing an intervention and looking at what happens to patients. Because if we're going to roll it out into the real world, people need to use it. So this means that maybe the clinicians and the staff members have an input into what happens, so we better look at what they're doing, right? And maybe the payment mechanisms have some input to whether I'm going to do this or not, or how well I'm going to do it. So we better look at that. So we tend to do this multi-layer thing, where we look at outcomes for patients, but the next layer out from patients are providers and teams, organizations, policy and payment, or community. Do you see what I mean by layers? Like if you're kind of going out from the patient, what are all the different layers of influence? So you're studying all those things. to see where, if it's going to break down and how it implements, where is that breakdown? Okay, so here are a few things. You've got the handouts, so you can look at this later. But I'm just kind of trying to highlight some of the differences of the look and feel of a D&I study. Now, the key thing to remember is you need an evidence-based intervention. So somehow you need to know it works. If it doesn't work, then you're introducing a lot of messiness, right?
How do you know that it works? So it's the intervention, I do child with obesity, so the intervention worked in a study in Philadelphia in this cohort or this sample of people, and they did, I don't know, a 12-week intervention, X, Y, and Z, and it worked because they had some change of BMI Z-score or something like that. Now I have it. Now I would take it into implementation science?
Right.
Okay.
Now there's an,
so it has to be,
there's an
that's evidence-based?
argument out there that you should test it first in a kind of tightly efficacious sort of way first, keeping in mind how it would really look if you actually needed to spread it, okay? So you're keeping that in mind. And then you move to a D&I study. That's the safer path, because if you submit a D&I proposal and you don't have any evidence that something works, you're probably going to get it rejected, okay? So you've got something that works. What's something that you know works? Let's say that program works. Then you want to say, okay, the grant paid for this. They paid for the people to do the program. They had a highly select group of people who really wanted to do this. Like all these like ideal circumstances were there. But you need to understand how that can be taken up at other places besides in Philadelphia. So that's the D&I. But the thing is, you're still making sure that it's effective for patients. Because what happens is you could study the D&I of it, and it totally falls apart in terms of the outcomes. That wouldn't be good. So something happened there. So to have an effect, you've got to have an intervention that has potential to work and a way that it actually gets used. You need both of those things. And so sometimes when things get rolled out, this was the problem with a lot of care management stuff, is in the tightly controlled studies, it was working really well. And then when it was implemented widely, they weren't getting good outcomes. And so we started doing studies saying, what happened? One of the things that we found out that happened was it was getting taken up by these chronic disease companies who are making money off doing telephonic chronic disease management. And that lost the essence of what you got in the study, which is someone there with you in the practice doing this with you. So something got lost in the translation to this other model of delivery that it wasn't working well. And actually what has happened is a lot of those chronic disease management companies have kind of gone out of business. And health plans that were doing it that way have stopped doing it. And they're investing more in payment mechanisms to pay for your practices to have care managers in them. So that's an example of how things can fall apart when they go to real world. Is this all making sense? Are you following me? Okay. So you guys already started a great discussion with you. So an explanatory study where you're trying to build the evidence, you're going to have, this is something called the Precis tool. You can Google this and it'll come up with a website. I think it's Precis.org or Precis2.org or whatever. And I'm going to show you another slide with this filled out in two different ways. But if you're trying to look at the evidence for effectiveness, you're going to want a tight population. You're going to give a 1. You're going to not want people with things that will mess up your study. All right? You don't want everybody. You just want certain people with certain good characteristics to study your intervention. You're going to want to only recruit certain kinds of people. You want to do it at your clinical research centers to control everything, right? So you can see how these factors around this wheel will look like this more over here on the left for a highly explanatory or efficacy trial, and over here on the right for more of a pragmatic or a D&I trial. Because what you're trying to study is the real worldness. So you're going to let whoever clinically come and do this, right? Because that's who you would do if you were a clinician, right? You're not going to just say, oh, I don't want to treat you. You're going to mess up my data. No, go away. You have to treat all your patients, right? So you're going to include everyone. You're going to look at adaptation and flexibility and track that. So, someone who takes up your obesity program and they decide to have community health workers deliver it instead of registered dietitians or something, you have to set your parameters of what you're trying to do. But that might be something that they decide is really important to their Spanish-speaking population who needs cultural adaptation. Like that might be more important. So there's some things that are a little bit flexible. This is a great tool if you think you're ready for more of a D&I type of study to take this. So you can go on the website. They have lots of examples. You can kind of score yourself because you're like, what's a 1 versus a 2, whatever. The idea is, does it look a little bit more like that or does it look a little bit more like that? That's the big picture. Because if you're trying to study real world, you got to throw the constraints off. Is this less rigorous? Does this feel like it's less rigorous to you? Yeah. You're not sure? A lot of people who are trained in very tightly controlled clinical trials start going, oh, how do you know what you got? This is really funky. I don't know. What I propose to you is it's just different, and you have to use different methods. Basically, you're going to measure a lot more stuff, okay? You're not going to just look at, here's what we did, everything's controlled, what are our outcomes, and we're going to believe that our outcomes are only the result of what we did. Because we randomized, and we kept a tight population, and we followed up with them a lot, and we really watched everything they did, and we used a ton of measurements and paid them to be here for 2 hours and get booked and product, all of that. So the outcomes start looking, have anyone ever heard of re-aim? Where have you heard it?
Allicam.
What do you think it is? Don't answer it too much. Okay. So re-aim is one of the kind of main frameworks to hold D&I research. Russ Glasgow developed it, so he's like internationally famous for developing re-aim. But it's a way of thinking about what your outcomes might be with a D&I study, okay? And so I'm going to walk through what each part is. So there's a reason R and E have a dash before the AIM. The R and E are what you do with an efficacy study. You're looking at which patients were reached and what happened to them. Okay? So that's what you do in any other study. You still do that with D&I because you want to know what happened to people, right? The whole idea of doing this stuff is to help your patients be healthier, right? Or at least have a better care experience or something. That's the point of it. So the R and the E are patient level. People get really confused and they think, getting providers to adopt this intervention is reach. Nope, that's adoption. All right? So I'm just saying the pure use of re-aim. But notice the AIM, this has to do with other stuff. Adoption is what settings, which hospitals take it up, and which people within those settings take it up. So this is the initial adoption. How many people take up your target zero thing? You try to spread it to, 5 other hospitals, and 3 of them start doing it. And within the 3, out of the 20 physicians, 10 use it. That's adoption. All right? Implementation is all the stuff that happens. So at those 10 hospitals with those 10 physicians, 3 hospitals with the 10 physicians, what do? Do they actually do it like they're supposed to? Or did they not do it like they're supposed to? Whatever that is. I don't know. How much does this thing cost? If it takes you 20 minutes to do this, and 20 minutes of you costs X number of dollars, and you multiply that by all the physicians that are doing it.
3 hospitals, 300 physicians.
Okay. What happened?
A little feedback.
Okay, that was freaky. All right. It's horrible to hear yourself. All right, so that might be really costly, and the hospital administrators might say, no, we're not going to do that because that's just too much time, and time is money. Maybe, so I work with Dan Motlock, who does a lot with shared decision making. And he tries to get physicians to use decision aids to help patients decide whether to choose like an LVAD, left ventricular assist device. If they don't do it, they might die, okay? If I'm a physician and I kind of go, I don't want my patients to die, I'm not going to really do this. That's kind of more of a mental model cognitive issue with implementation. There's an inconsistent belief system. So there's all kinds of things in this implementation bucket. Things that can come up, why they don't work. All right? And then maintenance has to do with the extent to which something becomes a routine part of practice. All right? So you could do, a weight loss intervention for kids, and they do it a couple of times, but then all these other factors intervene, and then it just doesn't get sustained. So sustainability of good interventions is really, really important. So those are some of the things you want to look at in a D&I study that are in addition to what you would do with a regular, I'll just call it regular study.
Do you look at all of those within one study? Like if it's
Yes.
an RO1, so within
Yes.
5 years, you have to
Yes.
plan even the maintenance.
Yes, it's so fun.
Wow. Okay.
So one of the things, I'm not going to get into this today, but if you really, because this is just an introduction, but if you're really excited about D&I, it's very mixed methods. So what I mean by mixed methods is you don't only have quantitative, like your clinical results, but you're doing a lot of qualitative at the same time, and you're mixing them. All right? Not many D&I studies just use quantitative anymore and don't include some qualitative. So qualitative are interviews and observations and document review and all that kind of stuff, because you got to know what's actually going on. If they're changing things and adapting it, that could be good, but if you don't know it, how do you know what's going on? So maybe what you do is you titrate your analysis a little differently because you know they didn't fully do it, or these issues were a barrier. Okay, so, but your actual outcomes, depending on the kind of D&I study you have, there's these hybrid types, and I don't have time to get into it, but a hybrid type 1, your focus is on the effectiveness, the patient stuff. Well, you're kind of looking at this other stuff, but you're not doing anything with it. A type 3 is you're really focusing on the implementation factors, the aim part. And then you're kind of secondarily looking, okay, does this still help patients? And then a 2 would be in the middle. In a pure implementation study, you wouldn't even look at the RE parts. We know this works. We know it works in lots of settings. We're experimenting, this is a whole different area, on different implementation strategies. So we're going to study whether audit and feedback versus training versus practice facilitation are better to get this thing to happen. So that's where you experimentally study the implementation strategy, which you can do. Am I getting people really confused, or is this kind of straightforward? Okay. So I'm just going to show you a couple of frameworks just to kind of get you excited. Yeah, excited. So one of the things that really helps with D&I is to have frameworks, models, and theories to guide you. So one of them is, so there's a bunch of them. And I'm going to show you a website where you can look at them all, okay? But here's an example of one where it helps you look at what implementation factors might be influencing what's going on. This particular one is really popular. It's called the Consolidated Framework for Implementation Research, which is pronounced CFR. Okay? So CFR, what CFR does, and it helps you think about all the different buckets of places that can creep into making your implementation not work. So one of those places is the outer setting. There's no way to pay for this. That could affect your implementation, right? The intervention itself. This is 12 sessions of 2 hours each. That's just not going to fly with our patients. They can't come here to the hospital 12 times for 2 hours because they're from Kansas. I don't know, whatever. The inner setting. So what are the factors here in the hospital that make it, you know? The individuals involved. So this is not just the patients, but the people who are trying to implement this, and then the process. So for all of these things, there are subdomains underneath, and there's a bunch of them, and it's like 30-something total. But we're working with Telegen right now, as an example. Here. So I do get some money. This is my conflict of interest. I do get some money from Telegen. What Telegen does is they get money to try to implement Medicare and Medicaid policy, and they were trying to reduce readmissions. Okay, so people go to the hospital, and they're supposed to be well and go home and not come back, because the hospital doesn't make more money if they come back, right? So we don't want them to come back because we want them to be well, and then we don't want it to cost us money. So they're using CFR to try to examine all the different reasons why the programs that got implemented across the country didn't reduce readmissions. Like, what about those programs didn't work? Okay, so this is just an example of one framework. Here's another framework. This one's from our buddies in Canada. In Canada, they don't call it D&I. In Canada, they call it knowledge translation. That's kind of interesting. It's the same thing. It's just called knowledge translation. The difference with this model, this is called knowledge to action. It looks a little bit more QI-ish, doesn't it? It reminds me of QI, because what you're doing is down here, you're identifying a problem, you're coming up with something, you're adapting it, you're assessing the barriers, you're going to tailor it, you monitor its use, you evaluate outcomes, you try to sustain it, you do it again. So this is more of like a process framework that you move through to try to get something to be adapted and taken up in practice. So this is more like a how you would get it done, not just the buckets to look at. Does that make sense? This is if you're developing a program. So this is like a program development framework. It's called replicating effective programs. So say you want to, I have a postdoc, and she's trying to take cognitive behavioral therapy, she's a clinical psychologist, cognitive behavioral therapy, and get it to work with cancer patients with pain. So she's using this to think about all the things she needs to do to adapt a program for this population. So you can see how you start off with thinking about the preconditions, what happens before implementation, the implementation things you need, and then how to maintain it. So this is more like a program development framework. Yeah.
So in like a 5-year grant, you are doing all this implementation and you notice that it's not working, this strategy is not working, but this strategy is working. Do you then change it before you monitor maintenance?
Depends on what you said in your proposal, but
is that something that you would think that when you're developing it, you're going to have to change, you might change it, right? You wouldn't want to spend the rest of the 3 years if, a year 2, you find out this is working better this way. So is there room
if
for
it's
that?
not working well anywhere,
Yeah.
then I would say yes. But we love variability. Like,
so you just watch it.
Yeah,
Okay.
like if it's working there, but not there, and there, but sort of there, that's awesome. Because what you got is, well, what is going on there that's not going on there, right? And then you can say, you can better inform the field.
Coming out. Yeah.
Oh, you need these things in place to make this work well. So if you don't have these things in place, maybe this isn't where you should focus right now. But if it's not working anywhere, I think you got to step back and,
So is there a model that encompasses that for change?
I think there are lots of models you could consider, but it's this is the trick, finding the one that fits for what you want. So anyway, I'm just giving you some examples. This website on the bottom, called dissemination.implementation.org, it's got a whole bunch of them. I don't know if it's got all of them, but a whole bunch of them in there. And what you can do is just pick select, and then there's some checklists. I didn't want to be connected, so I'm not showing you this in real time. But if you go on there, you can select, I want something to study dissemination more, or I want something to study implementation more. I want something that's going to help me focus on a provider level intervention. I want something that's going to help me focus on program adaptation. And you can search, and it'll give you ideas, and then you can click on the model, and it'll show you some key references and explain it. So it helps you. It's not a panacea for everything, but it gets you started. So that's one of the things. All right, so I'm just going to give you a few more references. If you would like to learn more, this is our website. If you put into Google dissemination and implementation research in Colorado, you will get our website. Okay, so this is on the Accords website. Since you're all here, we are here to serve you. So we might want to come here first. So I had my assistant pull this a couple of days ago, but here's the upcoming things that are going on. And this is kept updated. Here's what we do, and the next slide I'm going to highlight that a little bit more. We're hiring. You know any mid-level D&I people, send them to us. We're trying to hire more. But over here is what we do, who we are. If you want to request a consultation, we provide free consultations on D&I if that's something that you want to do. You just push the button, fill out the online form, and it comes to me. I'm the person. I'm like the little wizard in the Wizard of Oz behind the curtain. It's me. So you get me, and then we have a team of people that I can connect you with who would be best for you.
Include projects at Children's also?
Yeah. We're funded by Children's and the school Nancy. So, yes. Some questions. We have a ton of resources. We have ebooks. We have interactive tools. We have like lots of things that either we've developed or other people have developed. So there's lots of stuff there. What we do, we provide consultation. We create collaborative learning partnerships. So we are often co-investigators on grants. If you're going to do a D&I study, a real front and center D&I study, strongly, strongly, strongly recommend that you have a D&I person as a co-investigator. So I'm on one of the main study sections for HRQ. There's about 2 or 3 of us in the room. If someone tries to submit a D&I proposal and they don't have a D&I person, and you can tell, it doesn't get funded. Not that we have, or a clique or group, but there's certain things you look for. And when they're missing, you know that it's not going to be a serious study. We conduct research, so we try to build the field of D&I. We have online resources and support. And we do a lot of like workshops and seminars and talks and things like that. We just had Designing for Dissemination last week? No, it was the week before.
Beginning of October.
It was anyway. Last week was the Accords retreat. It was before that. So feel free to contact us if you want any help. If you're really serious and you really love D&I and you want lots of training, I'm just going to highlight this thing. Impact is our K-12. It's from the National Heart, Lung, Blood Institute. We have 3 scholars this year, but you have to be focused on a heart, lung, blood something, all right? Sleep. Oh, they added sleep. Heart, lung, blood, sleep. But you can apply for that program. You do not have to be a physician. It's PhD or MD. Amy Tyler is in the K-12 program. If any of you know Amy Tyler, she's a hospitalist here at Children's. And she is interested in studying de-implementation, which I didn't get into. That means stopping things that don't work because they're whatever reason. But it's hard to stop doing certain things. These are other training programs that are available nationally that you have to apply to get into. If you're a mental health professional, this is IRI. If you're interested in cancer, this is at Washington University in St. Louis. You don't have to move there or live there. It's virtual. You go visit, all right? TIDIRC and TIDIR are the 2 main national programs of training. Our postdoc just finished TIDIRC, so that's cancer. So those are more intensive training. If you just want to learn a little bit more, there is a conference called Dissemination Implementation Research in Health. It's put on by Academy Health. It's December 3rd through 5th. It's in Washington, D.C. So that's another place you can go for information. On the left is this book called Dissemination Implementation Research in Health. A lot of people refer to it, but as the D&I Bible. So you can get a lot of information out of that book. It just came out a couple months ago. Oh no, 6 months ago. Really, it came out mostly like January. And then there's more specialized books coming out. Like this is on implementation in cancer. So, all right. So that's the end of my talk. I'm supposed to mention that next week is Dan Matlock. I told you about him already, shared decision-making stuff. So he's going to be next week, and I think that's me. So I did get done a little early. What questions? What else should we talk about? What are you thinking?
I like that you gave us a lot of resources. I think that's good.
Okay.
Do you guys get involved with, I know you were saying that QI is like a little different, but do you guys get involved and help out with QI initiatives? Or is it mostly like, how do we implement evidence-based?
Thank you.
Yeah, thank you. It's more QI, studying QI as an implementation strategy type thing. Yes.
Okay.
Just standard. So, do you know Amy Tyler? Do you know who she is?
I don't know.
Okay. So she leads something related to QI here in the hospital. Okay. She did QI for a while, and she was kind of getting a little frustrated, feeling like, is any of this really working? How do we know what works? Blah, blah, blah. And then so she's kind of jumped out and decided, I want to be a D&I scientist because I want to be able to study all these strategies. And then she does a lot with like bronchiolitis. That's kind of her main research project right now. Is, I guess with bronchiolitis, you're not supposed to prescribe all kinds of stuff. You're supposed to just kind of watch it. But it's really hard to not do stuff because parents are like, do something, but the evidence really isn't there to do something, So she's looking at de-implementation. What does it take to stop doing something? It's similar but different than implementation. It's kind of like stopping smoking versus starting exercise. Not exactly the same thing, but there are some principles that are really shared. So I think if you want to study like maybe different implementation strategies or QI strategies and see which one works better, that would be like a good D&I question.
Like, there any guidelines out there about which ones tend to work better?
Well,
Yeah.
Yes
How
and no, but it's kind of a big mess right now. There's some work by Byron Powell, a little bit, that are trying to look at sorting implementation strategies and which ones, what they all are. So like kind of a compendium of them, and then which ones seem to work for which kind of. There's like this. I think of it like the game of Clue. It's almost like it was Colonel Mustard in the library with the wrench, it's kind of like that, it's like the problem, the context, and the, implementation strategy, you have to kind of hit the sweet spot to make it work, right? So that's a key area of D&I. We just submitted a grant proposal to develop a process to help clinicians implement guidelines using this process, and we got a score, but I don't think it's going to get funded to do exactly that. It was a little too much, trust me, we know what we're doing. Like, we're going to develop this grand thing, trust us. So I think that's probably what happened is, it's a little easier to review a proposal that says, we're going to look at the guideline for AFib, and we're going to look at what implementation strategies fit for that. And we said, we're going to look at all kinds of implementation strategies and see how they work with lots of guidelines and develop approach or a pathway so that places can figure out how to determine which one fits for them. So that was a little too ethereal, I think, for reviewers. I don't know. I don't have the summary statement yet, but
because where it seems like, and this is probably just me not understanding it, but this sort of the gap, there's like projects that specifically look at D&I, and then there's sort of quality improvements type projects, but trying to figure out the best D&I strategy to get either some sort of evidence-based medicine or QI initiative to be effective. I guess I'm wondering how we sort of bridge that gap.
Yeah, well, part of it is what we call implementation climate. So we know certain things. You got good leaders, good teams, good meaning a broad term for lots of things. Like people communicate and they respect each other and they get things done and productivity. And so you can read the leadership and team literature on that. But like if you've got a good leader and good team, probably whatever you come in with, if it's a priority, is going to go a lot better than these places that don't have that. So part of it is just what's going on there to begin with, right? Regardless of whatever your intervention is. So that's where I think quality improvement, and then have you heard of learning health systems? Like learning, that's a big thing now. Learning health systems is this concept that people work together to continually ask questions, have a, environment or culture of inquiry. You answer questions, you're constantly learning. And so those kinds of things underpin whatever you're doing. So that's part of it. But the other is what strategy works with what. So let's say your intervention, I keep picking on yours, but say you've got an organization where you decide you're going to do audit and feedback. If your organization is a learning health system, and that's an opportunity for learning, giving you audit, you feedback, and sharing what you did compared to everyone else in an open forum might be a great thing. It's like we're all here to learn and see, I can see you did better, so I'm going to ask you how you did that. So that might be a great strategy for something like you have. But take another organization, and maybe you get attacked in groups, and it's very punitive, and that could be a disaster. Everybody could quit, I mean, so you see what I mean? It's not just strategy. It's not just the intervention, but it's how that fits with what you have to start with. So QI is one mechanism to try to get people to be thinking about doing a better job, so that you can get better outcomes. The thing where QI kind of falls apart is, it doesn't fall apart, but it can fall apart, is what I see is these small tests of change. You have rapid learning, you apply it. If it's not something immediately available to you already, you tend to kind of have to put that off the table. Like you can't do it with the existing team that you have in a small way. So these bigger, blow up the whole, things are harder to test. Because unless you have like a QI institute that gives you free money to try out new things, it seems like you're limited by that. The other thing is people tend to try out implementation strategies that they know about, and there's a lot of them that they don't know about. So you tend to get things like training, audit and feedback, prompts, things like that are a little bit, but there's a lot other things you can do.
I think something I'm interested in is within an organization, so it has, the same culture, which of the strategies tend to be more effective for different types of interventions?
Right.
And I don't know, does D&I do work with that?
Yeah, there is some. Again, I would say look for Byron Powell and Joanne Kirchner are kind of two people who are in that territory. So they've published a little bit more on that. But no one's really paired. There are folks within the mental health area who have done more with mental health strategies. Like, it's like mood disorders and primary care, that kind of stuff. But it's coming. I think some strategies are more effective than others, period. And because some strategies are more adaptive, it's part of it. Like practice facilitation, having a coach come in and do some things. That's a more adaptive implementation strategy than training. No, training could be adaptive, I don't know, I'm just trying to think of something that's not adaptable, but, yeah.
Oh, sorry.
No, I think you had a question
Go,
too.
please, go ahead.
Okay. Now, I was just wondering, because you mentioned qualitative and quantitative studies, would you ever use qualitative studies to inform the implementation?
Yeah,
Like,
definitely.
maybe more information, or would you use kind of both when you're implementing, kind of parallel?
Well, we have a whole bunch of talks on mixed methods, and one of them is exploratory, where you use qualitative exploration to say, what would this look like? How would you do this? Involve stakeholders, which includes patients. If we offered this, would you come? And that's part of the designing for dissemination, is to ask those questions first. Because you don't want to get all the way down the road and then nobody wants to do your thing.
Definitely done that a lot in the ICU. With,
Yeah.
like,
Megan
QI.
Morris is going to speak on mixed methods in 2 weeks.
Oh, okay. All right. You had another question?
Oh, yeah. So you showed kind of the link and like kind of getting in touch with you guys about sort of projects. And so it seems like if somebody was going to be kind of filling that out and meeting with you guys, it would be with the specific aim of sort of researching either dissemination or implementation of some tool or guideline and like seeing how do we make it work. I'm just trying to understand how you guys typically fit in with that kind of.
Usually people approach us because they're writing a K or an R, or maybe they're further along and they're like, I'm really interested in solving this problem. Are you ICU?
Yeah.
Kids? All right. So I really want to make sure that sepsis guidelines are implemented properly. And we don't give them too much fluid. I don't know. I'm not a physician, but I am working with a physician who's in adult critical care, and that's his problem. He's like, we have guidelines, people are not following this. So you want that problem to be changed, and you realize I need to know something about how to change the implementation of this. So we get people coming to us and saying, I've done all these studies to develop these things to help, but they're not being taken up. This is why Dan Matlock got interested in D&I, because he was like, I get up in the morning to make sure that he's geriatric, my elderly patients make decisions that are good for them, in accordance with their values. And it makes me feel really bad when someone gets X device and it is not what they wanted, And so what I realize is we're developing all these things to help people do shared decision making, and they're not using them. And if they're not using them, it's not helping these elderly patients in the world. So that's where people come to a juncture of, I really want to study how to get this happening. So you're still the researcher interested in critical care for kids, but you have a partner that will help you figure out the methods.
Gotcha.
Okay? So it's really, if you're interested in studying it's not all like marketing or anything, but you're studying like, what is it that makes it happen or not happen, or to what extent, that kind of thing. So, all right, I think we're over. Thank you for coming. Thank you.